आज मैं आप लोगों के सामने स्क्रीनिंग एट बर्थ डिफेक्ट के बारे में बात करने आया हूं और इसमें ख़ास बात यह है कि आज मैं फादर ऑफ एसएनसीयू पुरुलिया मॉडल जो कि पूरे इंडिया में दिखाया जाता है उसके जनक डॉक्टर अरुण कुमारेंदु सिंह सर जो कि आरबीएसके के नेशनल एडवाइज़र हैं, उनकी लेक्चर से डेवलपमेंटल डिफेक्ट्स का पार्ट लोगों के सामने लाया हूं। प्लीज़ इसको आप पूरा सुने और इससे मुझे लगता है कि आप लोगों को काफ़ी चीज़ों की जानकारी मिलेगी।
What about neurodevelopmental? So this is the complication of prematurity and birth asphyxia, and this can be identified. For those who are interested in public health, Vadodara can tell you how to bring down prematurity and how to bring down birth asphyxia. My simple request is please follow this in your own family. So the first line is, when you say a term child that is beyond 37 weeks, it is not a term. This is a misnomer. We were all taught that beyond 37 weeks is term. That is a misnomer. Why do I say misnomer? Because it actually means that your lungs have matured, you don't require an SNCU. It doesn't tell about your brain maturity. So between 37 to 39 weeks, the brain very rapidly matures. So please understand that the golden message is allow all mothers to complete at least 39 weeks before terminating it for non-medical reason. Because extrauterine, the brain development will never be the same as intrauterine. Very simple message. Just tell every pregnancy should continue at least up to 39 weeks. So you will ask Dr. Singh, how did you say this? So when people studied all newborns who were born between 37 to 39 weeks and those between 39 to 41 weeks, it was found that between 37 to 39 weeks had more neurodevelopmental problems. So don't become a god yourself. That is why most labor pains will start beyond 39 weeks. Second thing is birth asphyxia. Vadodara is doing a wonderful job. Government Medical College Vadodara doesn't cut the umbilical cord, it allows the blood to go. So supposing a child does not cry, that means his brain is not getting oxygen because his lungs have not opened up. His pulmonary circulation has not opened up. So please resuscitate the child keeping the cord intact. The little amount of oxygen which was coming through the placenta was to protect the brain. By cutting that cord, you are denying the baby the oxygen. So nature was not a fool. It was for a purpose that it had placenta. It was for a purpose that it had such a long umbilical cord. And nature wanted that in the mother's womb, oxygen was coming through the placenta. After birth, it will come through air, through lungs. So there requires a time. Till it is established, you need to continue getting oxygen from the placenta. So all of you have understood. For those high-risk babies, those who are born preterm, those who are history of birth asphyxia, history of exchange, transfusion, they would require a more developmental assessment also for developmental delay. So a neurodevelopmental defect only in those who are admitted into your SNCU, were born premature they require to be screened for either birth asphyxia related neuromotor impairment or ROP. Out of every birth defect, 6 to 7 have a birth defect. But when you screen visible birth defect, you will get only 2 to 3, which is acceptable. So with a birth cohort of 2.6 crore, 17 lakh babies in our country are born and account for 9.6% of the newborn deaths. The major defects are only 5: congenital heart disease, neural tube defect, Down syndrome, hemoglobinopathies, and G6PD. 70% of birth defects are preventable. Under RBSK, you are going to identify it. So if you only screen in the first week, you will miss 40%. If you do 2 screening, one at birth and one at first month, you will be close to 70%. But if you screen up to 6 years repeatedly, you will come up to 96-97%. That is why under RBSK, we have multiple screening slots. So these are the different books which you will have to undertake and find your answers there. So for the delivery point doctors and nurses, there's a visible birth defect. There's also a book on functional birth to 6 weeks ASHA and 6 weeks to 6 years for the RBSK mobile health team consisting of Ayush doctor male, female, a nurse and a pharmacist. So identification, recording and reporting, initial management and counseling. So examination will be performed by the staff nurse ANM. You may require an extra nurse designated as newborn nurse. Every newborn nurse requires a brief examination within the first few months to see the respiration, heart rate, etc. But you also have to know the birth defect, head to toe and then back to front. So when and where? At birth, at all delivery points. Who will do it? Existing ANM staff and doctors. What help will you want? A simple torch, maybe a bell and a pictorial tool. So this is a simple thing. I always say, keep this poster and train. So when you see, I must look at the child, must take his weight, length, head circumference, must know his gestation, must see his movement, must see his tone. All newborns have flexed tone. That means both their hands and both their legs are flexed, especially in term children. In preterm children, you will get legs extended and hands extended. Actually, in the intrauterine limb, in the intrauterine, the legs flex first, then the trunk flexes, and then the hands flex, and then the neck flexes. So it is from bottom up. The legs will flex first, then the thighs, then the trunk, then the elbows, then the head. This is complete flexion tone. Now, if the child is born preterm, then it can be all is extended, or the legs are flexed and the hands are extended, but it can never be that hands are flexed and legs are extended. Again, I repeat that the cycle is पाँव पहले फ्लेक्स होगा, इसके बाद थाइस होगा, उसके बाद ट्रंक होगा, उसके बाद हाथ होगा, उसके बाद गर्दन होगी. लेकिन ऐसा नहीं हो सकता कि हाथ तो फ्लेक्स हैं और पाँव सीधा है. अगर ऐसा है, then it is always pathological. Then you need to do an MRI of the brain and see for some pathology. So what do you see in the abdomen? There is any abdominal distension due to any organ, in the hips, in the lower limbs for talipus, the back, midline defect, the genitalia, the femoral pulse, in the chest, the respiration, the heart sounds, heart murmur, the head and the face, the fontanelle, the face appearance, eye, mouth. So this is a simple thing which will help you. So after a baby is born, you see whether he is alive or not. Then you examine him for head to toe. If there is a birth defect, then you need to fill a form. So out of every 100 newborns, you'll find only 2 to 3. So you have to fill forms only among 100 for 2 to 3. And then you have to refer. So the state must make a directory with services available where. So if I am in Bharuch, where do I send my child? Or if he suffers from congenital heart disease, if he suffers from neural tube defect, where do I send? Who is going to pay for the transport? All this needs to be prepared like a directory, and you should have complete information before sending a child. यहाँ नहीं होता है बाहर जाओ, ऐसा नहीं बोलना है. You have to solve it. So examine head to toe, enlist the examination. If the examination is normal, well and good. If you find an abnormal defect, you try to find out how many are abnormal. Do you want confirmation test? So you can send him to the DIC where he can be confirmed, or if there's special investigations required, can be spent higher. So before you examine the newborn, you must remember that you must see the heart rate. So the heart rate when the child is awake, it is between 100 to 180. Why this? Because the heart rate, respiration, if they are not normal and you are trying to see the child for birth defect, you actually may lose the child. So whenever you have to touch the child, ask yourself, have you opened all the ornaments of your hand and fingers? Have you cleaned your hands properly? If you have cleaned it, then is the child awake? Is the child sleeping? And then whether the child is stable or not. Once the child is unstable, first try to stabilize. You can't say I was searching for birth defects and the child became unstable and died. So you should know what is the heart rate of a normal child. So when he's awake, it can go up to 180. When he's sleeping, it can go up to 160 from 80. The respiratory rate, it is 30 to 60 breaths per minute. The NIBP you can take. It may be difficult, but at least the systolic blood pressure is 80 in tertial. Tachycardia, if more than 160. Tachypnea, if there is a rapid breathing, which is more than 60. Hypotension defined if the blood pressure is less than 60. And then you can take the temperature, which is 36.5 to 37.5. So if it is less, then it is less. So this is how the head to toe examination will come.